Good afternoon, this is Dr. McDaniel. It's Thursday, April 25th, and let's see, I'm back in New Jersey now. Had a nice, short but sweet trip to Florida. Have family there. And today is the conclusion, the summary, the final countdown on my information for the week about uterine fibroids. So as usual, I'll just give a recap of everything and I'll add a few tidbits at the end. So let's see, uterine fibroids. Fibroids are also called myomas or fibromas. They are balls of uterine muscle. They can occur anywhere in the uterus. They can also occur in the cervix, cervical myomas, because the cervix is also made of muscle. There are 3 layers to the uterus: the skin, the meat, and the inner lining. And the fibroids in those areas are respectively called subserosal, intramural, and submucosal fibroids or myomas. 99% of fibroids are benign, so less than 1% turn into cancers. We call those cancer sarcomas. We don't have any way to screen or to assess if someone's fibroid is a sarcoma except for symptom-wise. So if someone's fibroid is growing rapidly, it's doubling or it's tripling in size in a very short amount of time, like less than 6 months, then that's abnormal growth, should be evaluated, and surgical intervention to remove it. Fibroids will always grow, and they're an abnormal response to a normal environment. So they feed off of the body's normal estrogen levels. That's why it is thought, although it hasn't been proven, but it's thought that if someone has fibroids and they go on one of the low-dose birth control pills, that will minimize the rate of growth because the low-dose birth control pills decrease the amount of circulating estrogen. Whereas with pregnancy, because pregnancy is a state of high estrogen levels, fibroids will always grow fairly rapidly with pregnancy, but surprisingly, or for unknown reasons, fibroids will usually grow quite quickly and relentlessly during pregnancy until around 24 weeks or 6 months. Then around that time, they stop growing. So because we know that estrogen is a state of pregnancy is a state of high estrogen levels and fibroids grow quickly, it's assumed that when someone is on the low-dose birth control pills, which is a state of low circulating estrogen levels, that will mitigate the growth of the fibroids. Hasn't been proven, but it only helps, it never hurts to go on the low-dose pills when you have uterine fibroids. We treat or address the fibroids based on the symptoms or the grief that someone's having from them. So fibroids can cause really heavy, long, bulky menstrual cycles. They can double or triple the amount of flow someone has naturally, and double or triple the length of time that someone's cycle is occurring. So, and that's predominantly if the fibroids are pooching, growing, and cobblestoning the lining inside the uterus. So if you have multiple or myriad of submucosal fibroids increasing the surface area of the uterus, that will increase the menstrual flow. We can treat the symptoms in that case. So predominantly the low-dose birth control pills are perfect because they lighten, shorten the cycle. Secondary to that would be the Depo-Provera shot or the implant, Nexplanon, Implanon, or the hormonal IUD, Mirena, Skyla, Liletta, or the Kylena. Those are all the same hormones, progesterone hormone. The progesterone counteracts your body's natural estrogen influence to build blood up for a cycle, so it counteracts it, so it minimizes the amount of flow that builds up, and in so doing, it decreases the amount of flow that comes out. Those are the predominant treatments for a heavy cycle, or what we call menorrhagia, due to fibroids. I mentioned earlier the evaluation process for that. The evaluation is always the same. It's going to be a urine culture to check for infection, an asymptomatic bladder infection, or chlamydia gonorrhea, which are both sexual infections that can cause inflammation, heavy flow, or abnormal bleeding. Blood draw to check hormones to see if there's a medical reason why someone has an abnormal flow. Pituitary, brain, thyroid, ovarian hormones. An ultrasound or a sonogram, it's the same thing, to evaluate if there are other reasons for the abnormal flow, and then potentially, depending on what the evaluation has produced or revealed, additional ultrasound called a saline infusion or a sonohystogram, or a uterine biopsy, which we call an endometrial biopsy because it's a sampling of the lining inside the uterus. That lining is called the endometrium. Once all of that process has been acted out, the diagnosis is confirmed that it's just the fibroids, cobblestone in the lining, then those, what we call medical treatments, would be appropriate. An intervention or a surgical treatment for heavy flow or long cycles would be uterine artery embolization. That would help flow. It would also help size. Or endometrial ablation, which I discussed previously, is a scarification process inside the lining of the uterus to decrease the normal tissue that builds up. So in so doing, you decrease the flow that builds up and that is shed. And those are the surgical procedures or interventions that can treat heavy flow. If someone is having problems with just the size of the uterus is increasing, so it's not so much that the lining is cobblestone and they have crazy long cycles, but the intramural or subserosal fibroids are building and building and bulking up. Someone can go from a normal size uterus, which is the size of a pear, about 5 to 6 centimeters, to a uterus that looks like they're 9 months pregnant or they're overdue for delivery. It can be quite huge, which would be not a 5 to 6 centimeter uterus, but a 40, even 42 centimeter uterus can be seen. Surgical intervention is predominantly used to address that. That would be a hysterectomy, so just removing the whole uterus, with or without the cervix, with or without the tubes and the ovaries, or plucking out individual fibroids that are making up the bulk of the massive size of the uterus. That plucking out procedure is called a myomectomy because fibroids are called myomas. Ectomy means to remove, so we're removing the individual fibroids or myomas. The hysterectomy can be done either in a traditional fashion where you open the belly, or it can be done with the camera laparoscopically or with robotic assistance, or it can actually be done vaginally, a vaginal hysterectomy going through the vagina. The myomectomy in the same fashion can be done in open exploratory laparotomy with the camera laparoscopically with robotic assistance, or vaginally if the fibroids are bulking up and a lot of them are also pooching into the lining. That can be done vaginally. That's with a camera that goes into the lining or into the cavity of the uterus. We call that a hysteroscopy. So a hysteroscopic myomectomy with or without an abdominal component. Those are the surgical interventions to debulk or to decrease the size of the big, large, bulky uterus. Uterine artery embolization will also achieve that same purpose. The caveats or the catches with uterine artery embolization is one, it's not done by a gynecologist, it's done by an interventional radiologist. An MRI is obtained to evaluate the blood flow to the uterus, because not just to the uterus but to the fibroids, because if there is not a great blood flow, then blocking off that blood flow won't decrease the size of those fibroids. So it has to have a rich blood flow in order to, when you deprive it of that blood flow, to decrease the size of those fibroids. Uterine artery embolization is a little bit tricky simply because it's hard to predict how much of a decrease in size that person will get. The radiologist can give an estimate, but it's not going to be as definitive as if you know you're going in and removing certain fibroids. And that process will not show its true result until 3 months after the procedure, occasionally up to 5 or 6 months after the procedure, when the full processes come to a conclusion. Those are the surgical interventions that will minimize the size or the bulk of the uterus. Lastly, there is a medication. It's called Lupron or Leuprolide. It's an antagonist to the brain that produces the hormones to stimulate estrogen from your ovaries. And the Lupron shots, the catch with them is they will put the person into a temporary menopause. Menopause is a state of very, very low estrogen levels, or what we call a hypoestrogenic state. Because you're shrinking those estrogen levels severely, the fibroids can't feed off of estrogen, they will shrink. That's what happens with menopause. In menopause, it's a state of low estrogen levels, so the fibroids will shrink. In general, an estimate of the shrinkage that one will obtain after menopause, and it's usually the bulk of the shrinkage occurs about within a year of menopause. The maximum effect you're going to get is about 2 years after menopause. So with menopause, on average, the uterus will shrink about 50 to 60% of whatever its status was with the fibroids before you went into menopause. Lupron shots can produce the same thing given enough time, but realistically, most women don't get the Lupron or the Leuprolide shots for 2 years. They'll get them for maybe 6 to 9 months. The catch is, once the shots are finished, your body's estrogen is going to build back up. You're going to get back to where you were prior to the shot. So the Lupron shot is not a definitive treatment that's going to give you long-term benefits, and therefore it's not used really to shrink it for a long-term benefit. The Lupron shots are used for 2 reasons. One, to stop the menstrual cycle, because that person's going through temporary menopause, and when you stop the menstrual cycle, you allow that person, if they were anemic, to build up their blood supplies before surgery. And it allows the uterus to shrink enough so that if one wanted to do a laparoscopic or a vaginal procedure, it allows the uterus to be small enough to achieve that end. So it's really an adjunct treatment. It's not a treatment by itself. Let's see, I think that's pretty much a good conclusion or summary of uterine fibroids, the diagnosis, the management, the treatment, the signs and symptoms of fibroids, and the different options. So I hope that was helpful. And today's Thursday. Thank you for visiting and joining me at GYN Corner. Tomorrow we'll start a new topic. Have a good night.